have the honor and the pleasure to be here in this successful event as usual, and I appreciate the kind invitation of the organizing committee for me and my colleagues to share in this session. First of all, it's something very special to me to introduce my professor, Professor Ali Indawi. Long time we were together, and I enjoyed and learned a lot from him over the past 30 years. Professor Indawi is going to give us a synopsis about breast cancer, molecular subtypes, as we need to identify a lot of the molecular key players playing in the backstage of disease, responsible for its aggressiveness or rather indolent course during the natural history of breast cancer. Professor Ali.
Thank you, Mr. Chairman, for nicely introducing me, and thanks for the organizing committee and Professor Dr. Nagla Abdelaziz. My talk today will be about the molecular subtypes of breast cancer. Actually, this is a very hot topic because it has changed a lot in the chemotherapy and treatment strategy of breast cancer. Well, until I identify anatomy هنا دي واحدة. فين اوكي. وبعدين فين الاب اند داون هنا عشان كل لابتوب غير التاني. Okay. So when you come to this topic, the molecular subtypes of breast cancer, the first question is what to test for evaluation of the subtype. Actually, we have three classical tests: estrogen receptor ER, progesterone receptor ER, and HER2. And now most of the oncologists will ask for the fourth type, which is Ki67, the proliferation marker. And concerning the rest of the markers, sometimes, not always, we need to do basal cell markers, which include cytokeratin 5/6, cytokeratin 14, and EGFR. And sometimes there is recommendation also for doing the androgen receptor markers, because this might affect and influence the therapy strategy. Now, the first question was what to test. And the second question is how to test. Well, immunohistochemistry actually works well in most of the cases, but however, we may in some selected cases need in situ hybridization, which can be done by FISH, fluorescent in situ hybridization, CISH, chromogen in situ hybridization, or the relatively more recent technique of DDD, the dual color, dual hapten, bright field in situ hybridization. Now, how to score? If we get ER and PR, it's nuclear staining, and scoring may be as simple as such: negative, weak, moderate, or strong, or better using the H score, which is a numerical score out of 8. And for evaluating and assessing the H score, we have to evaluate two issues. Number one, intensity scoring, which is out of 3. The nuclei may show no staining, this is score 0, or weak staining, score 1, moderate, score 2, or strong, score 3. And the percentage of scoring, this is out of 5. There may be no staining, score 0. Less than 1%, this is score 1. Between 1 and less than 10%, this is score 2. Between 10 and less than 33%, this is score 3. 33 to less than 66%, this is score 4. And more than 66%, this is score 5. then we sum these two scores together to get any of these figures. We may have 0/8, 2/8, and both are considered negative. Weakly positive is considered with the scores 3 and 4, moderately positive with the scores 5 and 6, and strongly positive with the scores 7 and 8. Now, these are two examples of nuclear staining for ER, and DR is the same. This is a strongly nuclear staining, and this is moderate nuclear staining, but if we come to the H score, both will be considered strong. Why? Because this is a score 3 in more than 66%, so it is actually score 8, H score 8. And this is a score 2 nuclear staining, but also in more than 66% of cases of the nuclei. So this is score 7 out of 8, also considered strong. So it's moderate nuclear staining, but the overall score will be strong. Concerning scoring of HER2, the updated ASCO CAP scoring, which is still working till last December, and of course till January, give these recommendations. Of course, HER2 is a membrane staining in contrast to the nuclear staining of ER and PR. Score 0 is considered when there is no staining or there is weak membrane staining in less than 10% of tumor cells. Score 1 plus is weak, incomplete membrane staining, but in more than 10% of tumor cells. Score 2 plus is considered when there is weak to moderate but complete membrane staining in more than 10% of tumor cells. Score 3 plus is strong complete membrane staining, and ASCO changes the figure 10% and said it should be more than 30% of tumor cells to consider it as score 3. Now the interpretation, score 0 and 1 plus are considered negative, score 3 is positive, score 2 plus is considered borderline and need in situ hybridization with the DISH, CISH or DDISH. This picture will show negative HER2 staining. This is score 1 where there is weak incomplete membrane staining of more than 10% of the tumor cells. This one is score definitely score 3 plus, very strong cell membrane staining of tumor cells. This one was equivocal. Some said that this is score 3, others said that this is score 2, but in with in situ hybridization, it proved to be score. There was amplification of the HER2 gene. Again, this is score 1. This is typical score 2, where there is complete membrane staining, but the stain is not strong, as in these two figures. This is score 3 HER2 mutant. When HER2 is borderline, we do the test by either by in situ hybridization, either FISH, CISH, or DDISH. Here, this figure will show the blue background is the nuclei. The red signals, this is amplification of HER2, so this is HER2 overexpression by DISH, and the brown signals are HER2 overexpression by CISH, chromogen in situ hybridization. Now, scoring of Ki-67, which is nuclear scoring, there is no strict consensus in this moment. Some consider the cutoff point as 14%. If 14% is high score, if less, it's low score. Recently, in last year, the cutoff point has changed and still controversial, but most agree that the cutoff point should be 20%, and the low score is below 10%. The high score is over 20%, and the borderline is between 10 and 20%. I'd like us to remind you that Ki-67, the proliferation marker, is very important in chemotherapy because it actually assesses the number of cells that are out of the GO phase. You know that the cell cycle includes resting phase, GO, and these 4 phases after that are the proliferation phase, including G1 phase, pre-synthesis, S phase, DNA synthesis, G2 phase, pre-mitosis, and M phase mitosis. So actually, Ki-67 Ki67 assesses these cells out of the GO space. This is very high proliferation of Ki67. Actually, in this figure, probably more than 60% of the nuclei are positive. This is also high proliferation, more than 20%, but less than the previous figure. And this is lower proliferation, less than 20%. Now, how to control the immunohistochemistry tests? This is very important in our work. ER and PR, we need always, and HER2 and KS, we need always to make sure that our test is valid. So we have to have a known positive control, which is the internal control in ER/PR, the normal mammary gland. If the internal control or the control in any of these markers is negative, the test is invalid. We cannot consider it as sound or correct test. Now we come to the molecular subtypes of breast cancer. We have first the classical molecular subtypes, and then we will proceed to the non-classical types. The classical molecular subtypes are actually four, but I put the fifth here because of its relation to the fourth type. We have the first two types are called the HR types, the hormone receptor types. If we know the anatomy of the mammary gland, it's lined by luminal cells, two-layered cells. Those towards the lumen are called luminal cells, and those towards the base are called basal cells. And breast cancer either arises from the luminal cells or from the basal cells. The luminal cells type are called hormone receptor positive types, or HR positive, that include luminal type A and luminal type B. Luminal type A, there is positive ER and or PR with negative HER2 and low Ki67. Luminal B is also positive for ER and or PR, and one or more or both of these two issues, HER2 positivity in contrast to this type, and or high Ki67. Of course, if HER2 is positive, this would be called triple positive breast cancer. Now, the other classical subtypes will include the HER2 triple type, which is ER and PR negative and HER2 positive with high Ki67, and the basal-like, which is triple negative for ER, PR, and HER2, but positive for basal markers, including one or more of these, cytokeratin 5/6, and or cytokeratin 14, and or EGFR, epidermal receptor, and also it shows high proliferation marker. And this is sometimes called the triple negative basal type, or basal positive. The fifth type that I include here is not النوع الخامس is called unclassifiable triple negative type, or unclassical triple negative type. It differs from the basal type. It differs from the basal type in being triple negative, but also basal marker negative. So this type is called the unclassifiable or the non-classical type. Now, this is a rapid comparison between the four classical types: luminal type A, luminal type B. حد معاه pointer تاني غير ده؟ HER2 type and the basal-like type. Luminal type A, as we have mentioned before, is positive for both ER and or PR, with negativity for HER2. Luminal B is also positive for ER and or PR, and may be positive for HER2. In such condition, we call it triple positive. And the HER2 type is negative for ER and PR, but positive for HER2. And the basal-like type is negative for ER, PR, and negative for HER2, so it's triple negative, but positive for basal markers such as cytokeratin 5/6. Concerning Ki67, it's low in luminal type A, it's higher in luminal B, and it's high in Ki67. It's high in the HER2 type and high in the basal-like type. Considering the histological grade, it has been found that luminal A has the lowest histological grade, luminal B higher grade, HER2 and basal-like have a high histological grade of breast cancer. And the common types that exhibit luminal A type are low-grade infiltrating duct carcinoma not otherwise specified, tubular carcinoma, Fabry-Foch carcinoma, and the classical lobular carcinoma. And those which exhibit luminal type B include infiltrating duct carcinoma otherwise specified, intermediate grade, and the micropapillary carcinoma. And the HER2 infiltrating duct carcinoma high grade, and the basal cell-like, or the basal-like infiltrating duct carcinoma high grade, medullary carcinoma, and metaplastic carcinoma. These are the most common types that express this molecular subtype. Well, considering treatment, I'm not going to talk much about this. However, we have to know something about. Luminal A perfectly responds to hormonal therapy, tamoxifen, and response to chemotherapy is very variable. Luminal B, its response to hormonal therapy is less than luminal A, but its response to chemotherapy is more variable but better than luminal A. HER2 type will need Herceptin. The basal-like is neither responds to hormone therapy nor to Herceptin, but there are other lines of treatment like cisplatin. Concerning the prognosis, it's best with luminal A. Luminal B is more aggressive and is not as good as luminal A. The HER2 type has poor prognosis. The basal-like type has poor prognosis, but this is not universal because some cases very well respond to chemotherapy and give good prognosis. This picture will compare the four classical luminal, the four classical types. This is luminal A. This is tubular carcinoma, strongly positive for ER/PR, negative for HER2. This type luminal B, which was infiltrating duct carcinoma otherwise specified, positive for ER/PR, and was in this case also positive for HER2, which is triple positive. And this case, HER2 type, high grade infiltrating duct carcinoma, it was negative for both ER/PR and positive for HER2, and the last figure is basal-like, which was triple negative, and if I add another picture, it should have been positive for the basal markers. Now, the second molecular subtype of breast cancer is cancer breast cancer according to both hormone receptor status and androgen receptor status. And there has been increasing concern with this type nowadays. Actually, we have 12 categories concerning this. We have 12 categories. We have the first four categories are luminal type A. The next four are luminal type B, and then other types. Luminal type A, ER positive, luminal type A, PR negative, AR negative, this is one category. For ER positive, luminal type A, PR negative, AR positive, this is another type. For ER positive, PR positive, AR negative, this is the third type. Or ER, PR positive, AR positive, this is triple positive concerning this issue type. The same can be repeated with luminal B. And we have finally the ER, PR negative, this is not hormonal type, this is not HR type because they are negative, but and AR negative, this is triple negative, and the ER, PR negative, AR positive type. This is a new entity concerning the androgen receptor, and it has a role in treatment chemotherapy of breast cancer. Now the third class is molecular subtypes of triple negative breast cancer. Actually, because this group is very important and this needs the most aggressive chemotherapy, so nowadays they talk about this group as a separate entity. We have this is a highly diverse group, and subtyping is very necessary to better identify targeted therapies. And sometimes analysis of gene expression will help a lot in identifying this group. It has been classified into six subtypes. Two basal-like called DL1 and DL2 subtypes, an immunomodulatory M type, a mesenchymal M type, a mesenchymal stem-like MSL type, and a luminal androgen receptor type, which is LAR subtype. This is triple negative androgen receptor positive, and this is a very important type because it has special line of treatment. Recent studies have suggested a great link between this triple negative molecular subtype and familial breast cancer, those cases with breast cancer gene positive. But still, the relation is opaque. Now, again, concerning the molecular subtype, triple negative type, as we have mentioned, analysis of gene expression is of extreme importance in therapy. And I will give you here some examples like basal-like type 1 and 2, they respond to cisplatin. The M and MS type respond to this therapy. The AR type responds to biclotamide therapy, which is an anti-androgen receptor antagonist, and so on. Now, the last group of the molecular subtypes is other molecular subtypes of breast cancer. We have the so-called basoluminal type, which, like the luminal type, is estrogen receptor positive, and like the basal type, is basal marker positive. For example, K5-6. We have also the recently described Claudin-Low type, which is often a triple negative type with abnormalities in cell junction proteins, including E-cadherin, and frequently wide diffusing infiltration of the stroma. And we have the next type, which is normal breast-like immunoprofile, which is like luminal type A, but when we study the gene expression, we find no much gene mutation abnormality, and still the place is open for other molecular subtypes. Actually, apart from the immunosuperior, other molecular tests to be done. Actually, there is no place to talk much about the Oncotype DX test, which is actually important in low-grade cancer, which is estrogen receptor negative lymph node status, and particularly in post-menopausal women, because the Oncotest the Oncotype DX test measures 21 genes and can predict which lady can benefit from chemotherapy. So, but only in low-grade cancer with ER positivity and lymph node negativity, that's to say stage 1 or 2 maximum. So this can, and also it applies for ductal carcinoma in situ, because it predicts which types of ductal carcinoma in situ will benefit from radiotherapy. But it's very costly, $3,000. فعايز بلاد فيها رفاهية. I have no much time to talk about this because it's a very big issue. And the second to be evaluated is breast cancer gene 1 and breast cancer gene 2, because particularly in familial cancer, there are a lot of patients who seek for bilateral prophylactic mastectomy, and I think all of you know the example of Angelina Jolie. With this issue, I think this is enough for the talk. Thank you.
Thanks, Dr. Ali, for this informative, updated lecture. Next speaker, Dr. Nagla Abdelrazak. She will highlight the imaging specific of breast cancer molecular subtypes, which have just Dr. Ali stated about, and the role of imaging in these subtypes.
just mentioned by Professor Ali Hindawi, we have different molecular subtypes, the luminal A, luminal B, luminal HER2 positive cancers, and triple negative cancer based on the classification of estrogen, progesterone receptors, Ki67, and the HER2 receptors. The identification of what the objective of this presentation, the identification of distinct molecular subtypes has changed breast cancer management. The correlation between mammographic appearance and the molecular subtypes for invasive breast cancer has not been yet extensively studied. Improved understanding of this association will help guide clinical decision making and provide information about underlying the tumor biology. There are few reports on the imaging features of this association to molecular subtypes. So I will try to give you a brief on what's published about imaging specific molecular subtypes. These are the different mammographic appearance of breast cancer. Speculated mass, microcalcification, mass with microcalcification, well-defined mass with central necrosis, architecture distortion, and asymmetric density. As regards the imaging specific of breast cancer molecular subtypes, we have a comprehensive analysis including triple-assessed triple cancer, HER2 positive, luminal A, and luminal B. In our center, we retrospectively reviewed 600 cases of breast cancer presenting from the year 2010-2014. And the results, I think you will find it quite interesting. We will assess the mammograms for the presence of mass asymmetry, distortion, and microcalcification in different, in correlation with the histopathology, triple negative, luminal A, luminal B, and the HER2 positive. We have found that it's quite interesting to know that the mass-like presentation is linked with the negativity of HER2 receptors. So the commonest presentation of a mass is found with triple negative cancer and also with HER negative cancers. And distortion is associated or linked to the hormone receptor positivity. So architecture distortion was found mostly in luminal A and luminal B cancers. And microcalcification, it's quite interesting to know that the microcalcification is very much linked with the positivity of HER receptors. So microcalcification was mostly encountered in HER2 positive cancers and negativity of the hormone receptors. When correlating this with the publications, in a recent study published in the year 2013, correlating the breast cancer subtype to the mammographic appearance, the mass presentation was found with HER-negative cancer and triple-negative cancer in 90% of cases, and the architecture distortion was found in the luminal subtypes, and the microcalcification was linked with the positivity of HER2 positive receptors and hormone expression in 90% of cases. So we have very similar results to such paper. In another study published in 2010, triple-negative breast cancer in correlation with the imaging and pathological findings. The study was designed to investigate the mammography and the ultrasound of triple-negative cancer in comparison to the other cancers. Mammography and ultrasound was done to 245 cases, and in these cases, mammography presentation of triple breast cancer was mostly mass presentation, and mass also was found with negative HER2 receptors and positive hormones. Architecture distortion was found in luminal A and the luminal B cancers linked with the hormone status, and the microcalcification was mostly found in HER negative cancers. So we can conclude that there is a strong characteristic association between the molecular subtype and the mammographic appearance, and this improved understanding of this association will help clinical decision making and provide information about the underlying tumor biology. What about the ultrasound? The ultrasound, the triple-negative breast cancer is usually presenting with a well-defined mass, regular outline mass, and very strange, also associated with posterior enhancement. This is the commonest presentation of triple-negative, and usually we found posterior enhancement when having lesion with fluid or cystic lesion, and this is explained in the triple-negative cancer by the presence of excess necrosis associated with triple-negative cancer. The luminal types of breast cancer are usually presenting in ultrasound by irregular shaped breast mass. The ultrasonography features of breast cancer shows areas of significant correlation to the molecular subtypes. What about the MRI? We have a recent publication about the MR features of breast cancer molecular subtypes in correlation to the molecular subtypes, and the purpose of the study was to evaluate the magnetic resonance appearance of breast cancer according to the intrinsic subtypes. The study included 116 cases. This table shows the results of the morphology and kinetics. You can see, as regards the mass margin, the irregular outline margin is found in luminal A cancers, and the irregular shaped mass is found with the HER2 positive cancers. As regards the intrinsic necrosis, it is found mostly in triple-negative cancers, and as regards the tumor extension, the extension beyond tumor enhancement beyond the mass is found with luminal B cancer and in HER positive cancers. As regards the kinetics, the persistent curve was found with luminal B cancer and also with HER positive cancer, and the washout curve was found with luminal E cancer, and the plateau curve was found with triple-negative cancer. Here is an example of 40 years luminal A breast cancer. You can see the irregular outline, mass presentation, and the curve is persistent. Here is a 71 HER2 positive cancer with a smooth outline mass and washout curve. And here we have a 69 years old triple-negative mass with intraluminal necrosis and a plateau pattern of curve, which are all criteria characteristics or linked with triple-negative cancer. So in conclusion, several MRI features might be used to predict intrinsic subtype of breast cancer, ER positive and HER negative breast cancer, and the presence of intraluminal necrosis is significantly associated with neoadjuvant chemotherapy non-response. Also, there is an association between the luminal B subtypes and the background enhancement in MRI. So to conclude, different types of breast cancer have different biological characteristics, mammographic and ultrasound and MRI features. Analysis of those features may help us to predict the type of breast cancer and its prognosis, and to select the optimal treatment plan for patients with different types of breast cancer. Publications about the imaging-specific molecular subtypes are few, and still it's a blind area needs further research and analysis. Thank you.
Thank you, Dr. Naglaa, for this interesting presentation. And in fact, the whole session today is very interesting, talking about the future of breast cancer. And here I would like to present dear colleague, Professor Mohsen Mukhtar, to talk to us about the tailored therapy according to the breast cancer molecular subtypes. Thank you.
Okay, thank you very much, Mr. Chairman. I'd first of all like to thank the organizers and especially Neglect for inviting me to be part of this meeting and this conference today. My task, or the task that Neglect gave me today, is to sort of give you an insight of what we as oncologists convey to our patients in terms of treatment strategies. And I think that's very important because once or if I try and give you that insight, maybe then the gap between the way we talk to patients is decreased, and I think that's definitely in the interest of the patient. Now, as these are my disclosures, as we've just heard, breast cancer is obviously not one disease. And today, what would I ask Professor Hindawi to give me in terms of the pathology for these patients? Obviously, I'd like to know whether this patient has an invasive disease or not. The histological subtype will differ and be differentiated. The grade, the size of the tumor, whether or not the margins are clear or not, the lymph nodes, whether or not they are present or they are positive. And definitely, or really important, is the molecular subtype of this patient. So what do I want today? I'd like to know the ER score and not whether it's positive or negative, because as Professor Hindawi said, a score of 3 is totally different from a score of 7. The PR score, HER2, Ki67, and in some cases I will ask for the 21 gene expression, and in some cases I will further go on to ask for BRCA mutations, and this is what I'm going to show you in the coming slides. Professor Hindawi clearly showed us that Ki67 less than 14% was the consensus in 2013 for the St. Gallen. It went up to 20%, or is going up to 20%, and I think in the coming month, in the next St. Gallen, dictating whether or not to give chemotherapy, it is going to go up to around 30%. These are the subtypes that have been shown previously. So, who should receive chemotherapy? If your patient has histological grade 3, you should be giving chemotherapy. High Ki67, over 25%, or probably in the coming weeks, it will be over 30%. Low hormonal status, so if your patient has an ER score or a PR score of 3 or 4, I think these are patients receiving chemotherapy. HER2 positive, triple negative breast cancer patients. Recurrence score, if you're going to do it for some patients, if they've got a high recurrence score, these patients should be receiving. If your patient has 3 positive lymph nodes at time of surgery, or you have seen a clump of lymph nodes at the time of doing a mammography or assessment of this patient, I think these are patients for chemotherapy. Age, we do differ a lot whether age or not. If a patient has a young age, less than 35, should she be receiving chemotherapy? I think with caution and with a lot of testing, patients even less than 35 can be spared giving chemotherapy. The second is, when do I give chemotherapy or neoadjuvant therapy before I go on for surgery? Now, any patient that has a tumor more than 1 centimeter is a candidate for giving neoadjuvant chemotherapy. Whether or not that is the practice, and in some subtypes of patients, I will not go for neoadjuvant chemotherapy. But it is to facilitate local therapy. I think this, again, will change in the next St. Gallen, because we do have now, if your patient receives or achieves a pathological complete remission, she will do better in terms of overall survival. It should contain anti-HER2 therapy if she is HER2 positive, and it can be in terms of hormonal therapy alone if your patient is postmenopausal, and it should be given for the maximum response when you're giving a postmenopausal patient hormonal therapy. So the most important thing when I'm going to give neoadjuvant chemotherapy is to achieve a pathological complete remission. And Neglect will be showing us how to assess that in the coming lecture using imaging techniques. So who will really benefit and which therapy to give for in terms of neoadjuvant chemotherapy? Now, what have we done with chemotherapy alone? I don't want you to remember the names, but I wanted to show you that giving this trial, the German group are the group that's really concerned with neoadjuvant therapy, and they've really done extensive research in this. And they had this trial giving 2 types of chemotherapy versus giving 3 types of chemotherapy for a longer period. And the longer chemotherapy and the more number of chemotherapy drugs you give, you achieve more pathological complete remission as well as partial remission as comparing to giving only 2 drugs. And this turns out to show you that conservative surgery is better when giving more chemotherapy. 75% did conservative surgery versus 65% of the patients. The second, another trial from the German group, is when to assess. So here they gave 2 cycles of chemotherapy, then they went and did assess the response, and then they dictated their treatment furtherly according to the response, whether giving the same treatment, changing the treatment, or giving more cycles of chemotherapy when the patient achieved a PR or CR. What they did show was that tailoring your therapy according to the response is important, and it is really important in patients who are of the luminal A and luminal B subtype. And in the patients who do not respond, changing your chemotherapy is important because this will turn out for a disease-free survival for these patients. And giving the responders 8 cycles of chemotherapy rather than 6 cycles is better. So coming out from all of this, patients who do have or are going to receive chemotherapy, giving more cycles of chemotherapy when they do respond is actually better for them. But not all of your subtypes are going to respond, because as you can see here, pathological complete remission in luminal A, as clearly shown by Professor Hindawi in the previous lecture, luminal A patients don't really respond to chemotherapy. Luminal Bs do better, HER2 and triple negative patients do definitely better. So if I was to decide based on this who to give chemotherapy, probably the HER2, the triple negative breast cancer patients, as well as some of the luminal B subtypes. This was the conclusion from that trial. Anti-HER2 therapy. We have had very recent data coming out last year and this year on dual combination of anti-HER2 therapy in terms of neoadjuvant therapy, because this is a very costly therapy, and maybe when we do prescribe this for your patients, some of your patients, when they get back to you, they'll be complaining about the price of all this, because we know now that the combination of anti-HER2 therapy, trastuzumab plus lapatinib, pertuzumab plus trastuzumab, and as well in combination with chemotherapy, does give you the highest pathological complete remission. And in some series, as you can see lower down here, it is around 60% for some of these patients. So dual anti-HER2 therapy probably is going to come in the next St. Gallen. Now, what was really interesting from coming out of some of these trials is that pathological complete remission translates into disease-free survival, and in the end will translate into an overall survival. That's why pathological complete remission becoming a surrogate marker, it is something that you can test for, because it will in turn give you disease-free survival as well as overall survival. Now, should triple-negative breast cancer be different? As we've just heard, triple-negative breast cancer, this was one of the recent trials. They showed giving platinum compounds as well as antivascular endothelial growth factor. The more you gave, if you gave platinum, it was better than without no platinum. With an antivascular endothelial growth factor, it was better than without a vascular endothelial growth factor. As for hormonal therapy, in terms of neoadjuvant therapy, this can be done in postmenopausal patients. You can see that it is as equally effective as chemotherapy. Chemotherapy is in blue. The 2 other anti-hormonal therapies, these were aromatase inhibitors. That's the one in the purple and green. You can see in terms of clinical, mammographic, as well as pathological complete remission, they do just as well as chemotherapy. So elderly ladies who are postmenopausal, you can go in for neoadjuvant hormonal therapy. In the premenopausal patients, this should never be done outside of a clinical trial. So, if I wanted to wrap up the neoadjuvant therapy, luminal A, I do have to assess my patient in the mid-cycle if I'm giving a chemotherapy, and it should be response-guided. Luminal B, I do expect a medium response. Again, reassess after 3 cycles of chemotherapy, and that's where your role comes in. If I'm treating a HER2 or a triple-negative patient, I know they're going to respond really well, and they are going to give you high responses as well as pathological complete remissions. Do reassess after 6 cycles. I personally do not recommend chemotherapy or neoadjuvant therapy for a luminal A patient if she can have a conservative surgery at the time. Adjuvant therapy, it's probably the same, even if in luminal A patients, it should be prescribed for patients it's going to benefit patients who have more than 4 positive lymph nodes, not patients who have a tumor less. So it should be dictated according to the tumor volume rather than just being positive. Luminal B, it is useful to give luminal B chemotherapy, and it should be anthracycline taxane based. There is no, and as well as anti-HER2 therapy if it is HER2 positive. And the duration of anti-HER2 therapy in terms of trastuzumab should be around 1 year or just 1 year. In chemotherapy for triple negative, again, this is adjuvant, so after surgery you have to give anthracyclines, taxanes, and I think this recommendation is going to change in a couple of weeks. It should contain platinum and it should be dose dense, so I'm giving the patient chemotherapy in shorter durations. If you're familiar with our prescription of chemotherapy, it's usually every 3 weeks. For patients who are triple negative, it's probably going to change to every 2 weeks rather than every 3 weeks. Hormonal therapy, because a lot of our patients now will be driven by this. You will see patients who are premenopausal receiving 10 years of tamoxifen rather than 5 years. This is for patients who have started off as being high risk, whether they had grade 3 tumors or they had lymph nodes that were positive. Ovarian function suppression plus an aromatase inhibitor. So you will find us prescribing for patients who are younger than 35 years ovarian function suppression. We've just had recent data on that a couple of weeks ago in San Antonio. Postmenopausal patients should have an aromatase inhibitor incorporated into their adjuvant therapy. So when will I test for the BRCA testing, or when will I push my patient to test for BRCA testing, as well as the Oncotype DX? 21 gene array, this should, as Dr. Hindawi clearly showed us, that patients with a high recurrence score are those that do benefit from chemotherapy. It has the ability to change your concept of whether or not to give chemotherapy. As you can see here in this data, you can see that 75% of the patients who were supposed to receive chemotherapy in the low and intermediate went on to receive hormonal therapy. Should be done, it should not be done if you have more than 4 positive lymph nodes. It should not be done in patients who are HER2 positive, and it should not be done if your tumor is less than 1 centimeter, because if it's less than 1 centimeter, you're not going to be giving chemotherapy anyway. If you have more than 4 positive lymph nodes, you are going to be giving chemotherapy anyway, so you can spare that for the patients. BRCA testing should be done in patients who are triple negative and less than 50 years of age at time of diagnosis. These are the guidelines coming out of the NHS in the UK, because they showed that patients who are triple negative with and less than 50 years, these are the ones that do have the highest percentage of BRCA mutations, and I think that is the patients that you should be doing it for. To wrap up, the adjuvant therapy, if your patient is HER2 positive, it is chemotherapy plus trastuzumab. If patient is HER2 negative and she is ER/PR negative, it is chemotherapy. If she is ER/PR positive, then if she's low risk, she could be spared chemotherapy, especially if you're going to give one of the more recent strategies of hormonal therapy. If she's high risk, then again, grade 3 positive lymph nodes, more than 3 positive lymph nodes, then it is tamoxifen. Now, before I close, I think the 3 next slides are the most important slides that I wanted to share with you, because as we see our patients in follow-up, you also see these patients in follow-up, and I think these slides are very important for our patients. Obesity in breast cancer. When you do have a patient who starts off with a body mass index that is more than 30% higher, you can see